this afternoon with Ryan Woodbury from Western Australia. Ryan is a clinician who works with patients who have osteoporosis and osteopenia, and he runs a bone density focused clinic over in, I guess it's not Perth, it's Western Australia. And he also has training in performing DEXA scans. So I've got him on today specifically to talk about DEXA scans. So welcome, Ryan.
Thanks for having me on. Hello.
Okay, so first of all, super basic, what is a DEXA scan?
Sure. DEXA is it's what it stands for. So it's dual energy X-ray absorptiometry. So it's a gold standard diagnostic for bone health disorders such as osteoporosis, but it's a very safe, low radiation based type of imaging that measures the mineral content, essentially calcium being one of the main ones inside of the bone. There's been some involvement with that. It starts to estimate fracture risk these days, but essentially it uses two beams that cross over with different energy levels, which measures the difference amount of density between the bone and the soft tissues. A bunch of calculations and algorithms with different machines that go on to then calculate the bone mineral density. And what a lot of patients get, or what we see as well, is the end result, which is the T score, the Z score. T score is the main one we're going off, which compares the patient's bone density in simple terms to that of a healthy younger adult. There's a bunch of data that they compare that to, and then the Z score being compared to someone of the same age and same sex. That's it
Yeah.
in a nutshell.
Yes. Okay, great. And I noticed that if people are under 50, they will diagnose osteoporosis or osteopenia based on the Z score. Um,
Yeah.
and my theory for that was it was because like if you're 40, your bone density might not have gone down that much relative to a young person yet for it to register on the T score, but it's checking if it's lower than other people your age. Is that why? Or is there another reason? Do you know?
Yeah.
Your
No, I'm
team?
quite sure. Yeah, good question, actually. I think it's because of that. And then also they compare it to someone of that age and sex, such as a Z score for them, because if it's not right or not adequate for someone of that age, then there might be other underlying pathology or something else causing it. So it sort of points it out as an indicator. And then most of the studies that are based, or the database for people on the Z scores, sorry, on the T scores, is for people over age 50, so they can't use it.
Oh, yeah. Okay, that makes sense.
Yeah.
And most of our clients who get a DEXA scan, who are referred by their GP, they just get lumbar spine and hip. Sometimes it's
Mm,
one hip. Whereas
yeah.
if people go to, say, a place that does one for body composition, they get the
Mm,
whole body.
yeah.
So are they different?
Yeah, they are in some way. Those, you mean like body composition scans, like, when the gyms do them or like dietitians sometimes do them? Is that what
Yes,
you're
but
referring to? Yeah.
that they're a DEXA though.
Yeah, they are. Yeah. So the same, using the same principle, which is the dual energy, the two X-ray beams, but for the body composition, they're comparing, I think it's fat versus lean mass, which is different indicators. And then not really, it's not the gold standard for diagnosing osteoporosis.
Mm.
Whereas the dual energy or DEXA scan for osteoporosis needs to be just looking at the proximal femur or the femoral neck and the total hip, and then the lumbar spine,
Okay.
because
And why
they're
is
the
that?
most predict. Yeah, good. That's what I was going to. So they're the most predictive areas of future fracture. So if we think of someone falling, more than likely they fall on their side, they might fracture the hip, or they might put their hand out and brace the fall with the wrist and then fracture the wrist, or they land on their bottom and they get compression load into the lumbar spine. So the three main areas that we like to look at. There's also differences in bone biology in those areas where we get more cortical, so more trabecular bone in the spine, different types of cortical bone in the femoral neck, and then the wrist is a bit plus or minus depending on whether the referring practitioner or even the radiology company does the wrist.
Hmm.
But yeah, anyways, most of the time it's just the spine and the hip.
Yeah, I've noticed that a few more people have wrist lately, but I
Yeah.
read that with wrist, it's
Mm,
not as sensitive to interventions to improve bone health, or like the turnover of the bone isn't as fast. Is that
yeah.
correct?
Yeah, partially true. Yeah. There's more cortical bone in that area, more harder bone. But the wrist does get used, yeah, depending on what the reasons for. So if someone else has other hyperparathyroidism or other immobility issues where they can't lay on the DEXA tape. Remember, you have to lay supine. Their hips are slightly internally rotated. So if we can't look at someone's hip or their spine because they've had a hip replacement, for example, or they've got severe osteoarthritis or obesity issues, and we can't get to their lower spine or we can't get to their femoral neck, then we may just use the wrists, especially for people who are very frail as well. They can't lay on the table completely supine.
Yeah, and I guess I see that a lot, that people's lumbar spine is often really good, as in it'll have a T-score of +2 or something
Mm.
like that, and then it'll say written on it that you can't, it's probably artificially elevated because of arthritis, meaning that
Yeah.
arthritis lays down lots of extra bits of bone. So I
Mm.
have thought for patients who have both hips replaced and severe lumbar spine arthritis, they don't have
Mm.
another. Yes, so the wrist makes sense there.
That's correct. Yeah, it was otherwise very overly estimated. The risk, there's some emerging research on that, and it's funny because someone comes back and their risk score might be, a T score might be a -3.0, and the hip and the lumbar spine are in the -1.8.
Yeah.
But there's some link to thyroid or hyperparathyroidism issues with that lately. So I might send you a couple of articles on that actually.
Yeah, because I've
Mm.
definitely noticed that in a few of people who've had the rest, it's sort of, well, worse. So I'll have to look into
Yeah,
why. And do they look at
yeah.
lumbar spine and hip because are those areas, like you said, they're more likely to fracture because that's where you're more likely to fall, I guess. But is it also that
Mm.
the bones there are the most susceptible to becoming osteoporotic?
Yeah, that's true. Yeah, definitely. Yeah, yeah. And it's the most easiest sort of areas to measure as well. Because this is the part that sort of had a debate about, is that they say osteoporosis is a skeletal systemic issue. And so if we just measure the hip and the spine, do I have it elsewhere in the body? And the more than likely the answer is yes.
Yeah. Yeah, for sure.
Yeah.
Yeah.
Mm.
But I suppose it might be, you might pick it up there first if those sites are more, maybe if it declines there more quickly than other areas, or we don't actually know that.
Don't actually know that. I think it's the
Okay.
most commonly fractured sites in populations who have been studied who have osteoporosis. They present to ED, and then it's a need a hip replacement or a spinal fusion or something, a fracture in the back, most likely because of osteoporosis. So then those areas are the ones that are scanned. I think it's also got something to do with the geometry of the beams and the way the technology measures it. But the contrary of that is that a lot of people who get compression fractures, if they fall, can actually occur in the thoracic spine. So then the argument is like, why don't we examine the thoracic spine? Um,
Yeah.
but I'm not sure on that yet. It's still unknown.
Yeah. Okay. And I know that there's some inaccuracies with the machine. Like I find now when I get patients coming through and they have had a change in their bone density, I'm
Mm.
always suspicious because I know how inaccurate machines are. It often says on the report that 5% is the minimum clinically important difference. So does that 5% like make up for inaccuracies of the machine? Like if they do it on the same machine and they have a 5% change in either direction, can you be pretty confident that it's actually changed?
Yeah, 5% is a pretty large number. Normally, you're weighing up computer error and human error. I would say that's normally small percentages. But the big thing is, yeah, definitely getting it done on the same machine at the same place, because normally those machines are calibrated that way.
But
So
yeah, because how does that
I,
work? Yeah.
yeah, it's a good question. Not too sure on the major physiology behind that, but the main companies that you might see is like G, Luna, or Hologic. They're the main ones, and it's got to do with different variances in the machine or the manufacturers, the way they design it. But the fan beam, the algorithm, and then the calculations, from what I understand, with different tube voltages and calibrations, that's the main gist of it. It gets pretty full on technical.
Yeah.
But I think that's the differences between it all. So then if you go into one machine that calibrates it differently or reads it differently versus another one, then they're both, don't get me wrong, they're both accurate and consistent in their results. Otherwise, they wouldn't be allowed for commercial use. But I think they differ in the way the results are read. Because I know some bio calibration has to go on. So if you came to me and you had Lunar X-ray, DEXA, and then you had another one, Hologic, would have to do some calculations to see if it's the same, see if there's a 5% improvement. But 5% is great. If someone can prove that, that's awesome.
So it wouldn't be that like you might get a T-score of minus 1.4 on one machine and a minus T-score, like say if you do it on Monday and then on Tuesday you go on a
Mm.
different machine. It wouldn't be so different that you are getting a different T-score. It's just that when they're trying to compare, it's harder. Is that right?
Yeah, that's correct. Yeah. Yeah.
Oh,
That's
that's
like the
reassuring.
difference with reliability and validity. So it would be reliable, same results would keep coming back. And it is valid essentially because the machine's operating. So I would say if you're going, same machine, same company, ideally the same technician, because all the calibrations and settings are normally the same. That's to be
Yeah.
like very harsh about it, but you can never control which staff is on.
Yeah. Okay, that's actually
Yeah.
reassuring.
Mm.
And I wanted to know what is the trabecular bone score? Because I noticed that as well.
The TDS, yeah, that's some new stuff. It's actually quite good what it's doing. I was getting confused the TBS and then the VFA. So actually, before we get to TBS, they're doing something called vertebral fracture assessment now. So when you're laying down on the X-ray or on the DEXA scan, they're looking at the vertebral column as well to assess for any vertebral fractures.
Oh, that's
Um,
cool.
yeah, it is cool. So some technology places, some DEXA scans will now have that if they choose to have that added to their machine. But the TBS is some other software analysis that's applied when they're doing the interpretation of the DEXA scan. Ideally, the standard spine area as well, but it gives an insight to bone quality and bone microarchitecture, in particular the trabecular bone. So it just helps, like if you think about DEXA and how sensitive it is, most of the time it's just measuring mineral content. And then that's why they're saying there's emerging evidence with REMS, Ecolite, which is showing more fragility fractures or more how susceptible someone is to having a fracture. So what the TBS is doing, adding that onto DEXA to assess that bone quality or the microarchitecture of the bone. And so essentially, it's just giving us more prediction of who could fracture quicker.
Okay.
Mm.
Yeah. And then there's also the fracture risk assessment tool where they put the percentage likelihood of a fracture in the next 10 to 20 years, is it?
Yeah, yeah, it is. Yeah,
So
yes.
how do does that take into account your age? Like how does it figure out, is it factoring in risk of falling or is it literally just like how do they
No, no,
work
they
with that?
don't really. Well, there's clinical risk factors that are involved on it. Make sure if you're using that tool, you're using the Australian one if you're in Australia, because there's different ones for different areas. I think maybe because of different DEXA scans or different socioeconomic socioeconomic status, the different demographics around the world, like Caucasian versus Asian versus, how they do all the different statistics on that. But yeah, it's an online tool that was developed to estimate someone's 10-year fracture risk. So you plug in a bunch of details like your T-score off your hip DEXA scan, and then clinical risk factors like the age, the sex, any previous fractures. Have your parent had any previous fractures? Steroid or glucocorticoid steroid use, alcohol, smoking, and then diabetes. So they're considering all these risk factors that contribute towards poor bone quality, and then that helps guide the treatment decisions. So I use that with my patients now. Always, that's on the intake sheet as well. So then you quickly plug it into the calculator, and you can give someone, a 10-year probability. But a lot of GPs, so in the RAC GP guidelines now, if you go in and say you're 50, so you're age 50, female, and you've gone in and menopause was at 48, you're diabetic, under height and weight for what your age should be. You've had a previous fracture when you're skiing and you broke your wrist or something like that. The GP should pick up on those things and be like, "Oh, yes, it sounds, we might send you for a DEXA scan." So the patient would have to go pay for the DEXA scan themselves, whereas because they wouldn't meet the Medicare criteria. So
Yeah.
it's a good assessment tool that clinicians are using, and then GPs are also using.
Okay, yeah, I noticed
Mm.
sometimes it's done on the DEXA report that we receive. They
Yeah,
have it on.
yeah.
So,
They do. Yeah, they do. Some use Garvin, which is another fracture tool, but I think the ANZ BMS, it's like our gold society in Australia for bone mineral density, they recommend Frax. But then there's also Frax Plus. So the UK came out with Frax Plus, and this is now takes into consideration other factors like someone's strength or balance. You have to pay for it though. So
okay,
as a
yeah.
clinician, we have to
Yeah.
pay for it, the software, and it's like an ongoing fee. So then the patient absorbs those costs, or you charge a patient more for that, or the patient
Yeah.
does it.
Okay, but that's really interesting because then you could see it going down, like improving over time if you were to
Yeah.
take that one.
Yeah, definitely. Yeah. And then you can still use the TBS as well, and the FRAX, which are good tools to monitor someone, as well as blood tests. Because then if you come back and you get a high trabecular score, indicates the trabecular bone is much more denser, minimal spaces between the bone, and then this is going to be better bone quality, lower fracture of risk. And if you come back another year and it's lower TBS score, you've got poor connectivity in the trabecular structure, larger spaces, someone's got weaker bone quality, they might be at higher risk of fracturing. So yeah, some good technology now. Rather than just a DEXA, you can have TBS, you can have FRAX. Paints a big picture.
And that probably would be more likely on those ones when you're getting referred from the GP to go and get your done, as opposed to just a DEXA scan that does lots of things at once. Yeah,
that's correct. Yeah. And then I would say if there's any vertebral mid back pain, or you've had a recent fall, or noticing you're hunching over more and you can't get a VFA, like the vertebral fracture assessment, then just go get a normal basic X-ray of your spine just to make sure there's no compression fractures.
Yeah. Okay, cool. That's really helpful.
Yeah, that's DEXA. Yeah, so it's our gold standard currently.
Yeah. Awesome. Okay, well, thank you so much for that.
It's all right. Anytime.